Good morning. My name is Dr. Wong. I'm a consultant cardiologist. Today, we have Associate Professor Dr. Raghu. He completed his MBBS from the prestigious Madras Medical College in Chennai, India. He then left for the UK, where he did his basic surgical training and obtained his FRCS in 1992. He then completed his higher surgical training in Ireland and specialized in hepatobiliary and transplant surgery. His research interests including T and B cells in the liver and ischemic reperfusion injury of the liver during transplantation. This research had led to a number of international publications, and he obtained his master in surgery from the National University of Ireland in 2003. He then moved to New York, and after finishing his fellowship in transplantation, continued to practice in India until he joined Perdana University, RCSI, as associate professor, lead in surgery, and senior cycle director. With that introduction, I want Prof. Raghu, you can start your presentation on aging and the liver. Thank you.
Thank you. Okay, thank you, Dr. Wong. Thanks for the introduction, and can I also thank the organizers for inviting me for this talk. It's always a pleasure to be here. What I've tried to do is I've tried to keep this. I know that the audience will be a very varied, not necessarily only medical. So I've tried to explain things, so that people can understand. So I think I just like to. What I'd like to do in this session is to go through some functions of the liver, what it's capable of doing, what it's not, what it cannot do, and whether and how certain diseases in certain situations may affect an older, and I say older within inverted commas, an older liver, not necessarily chronologically older, but old because of disease processes. So that's what I'll be covering in the next few minutes. So I'd like to start with the story of Prometheus. This is a Greek legend, and Prometheus was a god of fire. But there's one god above him, and that was Zeus. So Prometheus, what he did is he stole the fire from the gods. He himself was a god, and he gave it to humans. And because of that, he was punished by Zeus because he gave the secret of fire to humans. So what they did was Zeus tied him up to a mountain, the Caucasus, and set an eagle upon him. And the eagle would chew his liver slowly and would come back for more in a few weeks' time. And he would be alive all along. So how did that happen? Because even then, at that time, they knew that the liver would regenerate. The liver is the only organ in the body that can regenerate. So if you cut half the liver out, it can grow back. Okay, so that's what they knew at that time, and that's what the eagle was doing. It would chew half his liver, come back for more a little later after the liver had grown back. So that's the story of Prometheus. So since that time, it has been known to mankind that the liver can regenerate, and we use that particular function of the liver. We use that property of the liver for various treatments and other things that we do. So now, if you look at the normal liver, it is also unique in many other ways. It's got a dual blood supply. Normally, you will have one artery supplying an organ, and you have a venous drainage. Here, you have two blood supplies for the liver. One is through the hepatic artery that you see here in red, and the other is via the portal vein. Now, what happens is all this portal venous blood, where does it come from? It comes from the intestines. So once the food is absorbed, it goes straight into the portal vein and into the liver, where it's detoxified and then it's sent out. Okay, so this has an abundant reserve. The liver has an abundant reserve. So you can cut half the liver out and be pretty much normal after that, because of the regenerative capacity as well. The microcirculation of the liver is also very unique, because all these the sinusoids just bathe the liver cells and allows all the diffusion of all the material to take place. And this, this form of microcirculation allows for a lot of diffusion, and therefore, this is very, very important. This microcirculation, if it gets affected in any way, then the liver will start, misbehaving. But, luckily, that doesn't happen that often if you look after it. And also, other diseases such as diabetes and hypertension generally don't affect the liver, but they affect it indirectly, not directly. Indirectly, this microcirculation, although it's not touched by diabetes like how you have in the retina, in the kidney, the liver is not affected like that. But there are other effects of the disease that could affect this microcirculation. And as I was saying to you, you have to have at least 70% of liver damage before it even shows up. So a lot of people will be walking around with the damaged liver, but they won't know about it until it's too late. And that is the issue here, because whatever tests you do, your liver function, even in advanced liver disease, the liver function tests that we have today don't get altered that much, and that's good in a way, but that's also bad in a way, because you really don't know that one has a liver problem until you do certain other tests. But that's also a factor of the abundant reserve that the liver has. Now, I was telling you about how the blood gets absorbed from the intestines, and it goes into the portal venous system and into the liver. About 65% of that blood is portal venous blood that comes from the intestines after you've eaten, all the absorption of all the things that you've eaten. All that filters is filtered through the liver. Now, there's only about 30%, 35% of blood that goes to the hepatic artery itself. The artery that's supposed to be the major blood supply in the liver is not. And it's here this happens for a reason, because the liver detoxifies a lot of stuff that we eat. We eat a lot of stuff, we think is okay, but it's not. And you don't know it, because the liver has this fantastic immune system. It is considered now one of the later functions of the liver that we know about is that it's got an immune system of its own, and it's also very important for the entire immune system of the body, because it's got its own lymphocyte population. It's got special NK T cells, natural killer T cells that exist in the liver, and you can also see these. The beauty of these cells is that when you take out the liver and transplant it to somebody, you wash the liver out, you flush it out with cold solution, and then you put it into somebody else, and these cells still remain attached to the liver. So these are known as passenger lymphocytes, because they are passengers. They go from one person to another person, and these sets of lymphocytes are very unique to the liver itself, and it's important because they play a big role in tolerance after transplantation. And all these things can get affected. These can get affected depending on what disease is present in the liver, or during the aging process and during transplantation. So this is we did a lot of work on this, and I was only a small part of that. A lot of work that was being done, but it was exciting stuff, because they did a lot of work in the lab with this liver NK T cells and cancer as well of the liver. So there's a lot of things that are still happening. Now, what happens when the liver gets older? Now, you have this lipofuscin deposition. That's just a pigment. It's called an aging pigment, and you can see that in many organs, and liver is no exception. You have lipofuscin deposition, and a lot of studies have been done looking at the ability of the liver to actually excrete properly. Now, this is one of the functions of the liver. We always thought this was the main function, was to produce bile and to help digestion. That is only one of the functions, but this also can be depressed in an older liver. But does it make a difference? Not really. We don't think so. So what if it's 30% less? It's not going to affect the liver. It's not going to affect the person. So the significance of it is not known. There are some, as I said to you, microcirculatory changes. I talked to you about that microcirculation in the liver. That can get affected in older individuals. However, not that much, not if you've been looking after it reasonably well. Toxins can damage this microcirculation. There are changes within the mitochondria. Mitochondria are the powerhouses of cells, and they are responsible for metabolism, key metabolic functions. And these mitochondria, they get affected. Now, this is a little more of a serious issue. If you have mitochondrial changes in the liver, it does not do its metabolic functions properly. And again, as I said to you, if it does happen, in a small percentage, it's not going to change that much. But you're talking about a lot of damage to the liver before you can see it. Now, what also happens is you get if you do scans in older people, you will find that the liver shrinks. Again, the significance of this, we don't know, but the liver does shrink. And consequently, the blood flowing into the liver also decreases a little bit. We do something called CT volumetry. You can see those CT scans over there. These CT, is the mouse working? It is. Okay, so this is a CT scan. You can see that the liver has shrunk a little bit. This is an older but not cirrhotic liver. It almost looks like a liver with cirrhosis. It's not. If you look at the parenchyma here, it's pretty good. So this is a liver that is shrinking because of age, and you can also tell that the blood supply, if you look at it, not just in one image, but plenty of images, that the blood supply might also be decreased. And this is another way by which we do volumetry of the liver. This is a MAVIS scan, where we look at the blood flow into the liver, and we use this a lot for tumors that are lying very close to blood vessels. We want to know exactly what their alignment is, and we can tell that the liver has shrunk or not. And if the liver is too shrunk, then we can't operate on these people. So that's why in older people we are very careful doing surgical procedures, because their liver may be a little smaller for one thing, and secondly, it may have some microcirculatory changes, and it may not have the capacity to regenerate. So all that information we have to put together before we do any surgery for the more elderly population. So that is why all these tests, we have all this at our disposal, and we use them judiciously to make sure that that we assess the patients properly before any surgery. So as I was saying to you, in a healthy person, and I mean older, well, I don't necessarily mean chronologically older. Yes, that does make a difference. Yes, it does. But we've seen people with very severe liver disease at 60, and somebody who's 80 has a liver that's almost pristine. It's just amazing when you can see the quality of the liver. The edges are sharp. The color is an even color. It's not yellowish like fat deposition. It's not bumpy on the surface. And this sort of changes you see sometimes in people even as young as 50 or 60. But we sometimes operate on people who are even 80, provided they are fit, provided they have no other issues with them, no heart problems, no chest problems, and the liver, by doing a scan, if it looks all right, then we go ahead and operate on them. So, we do know that if you do operate on them, sometimes some of them, they will react badly. They will show their age after major surgery. They may not show it before, but once you put your knife on them, they will post-op, they'll get all sorts of complications. So you've got to be careful of that. So the response to injury, it takes longer to complete. Regeneration, as I said to you, the power of the liver to regenerate is slower. Complications are higher only because they have other issues such as cardiac and respiratory issues. And I might happily resect, probably about 50-60% of the liver in certain individuals, younger individuals. I don't have that luxury in an older individual, especially when you see all these changes. So the other thing is live donation of the liver is a popular thing in the East. In the West, we depend on diseased brain dead donors, whereas live donation is more popular in this part of the world. Older donors, we are very careful. Above 60 to 65, that range, we kind of we back off a little bit because we are concerned. You don't want anything to happen to a live donor. A dead donor is already dead, but a live donor, if you have a complication, that's a major problem. Somebody who's got no issues at all and you inflict an issue on them, and that can mean death. So in older individuals, we are very careful about allowing them to donate to maybe their wife or whoever, their loved one. So it restricts their wish to donate. And also, this is a well-known fact that you got to be careful about your dosage of drugs to older people, because the metabolism, it may not be metabolized well enough by the liver. And the adverse drug reactions are a little bit more in older people. You have to be very careful when you dose these drugs to older people. Now, let's talk about a few diseases that can affect the liver. Alcoholic liver disease. Now, people who drink a lot, there are certain limits to how much one can drink. And we have that, and that limit is around 20 to 22 units, 1 unit being 1 glass of wine, 50 ml glass of wine, or a 30 ml shot, or a pint of beer. So you exceed that more than 20 to 22 units continuously, that affects the liver. And it doesn't affect the liver immediately, it takes a while. As I said to you, the liver can regenerate, it can go on for quite some time. So you don't know the damage that's being done to your liver until it's a bit too late, and by then you're in your 6th or 7th decade of life. Unless you hit the bottle really hard and you have a genetic preponderance to having liver disease, then you will see it earlier. Otherwise, assuming your genes are good, you will see it in the 6th or 7th decade of life. And the complications are more severe. If you have an older person with a complication of the liver rather than a younger person, they will not be able to, they are suddenly thrown off balance. They decompensate very quickly, is what we call decompensation. And the other thing is, the fulminant hepatic failure is nothing but acute liver failure that happens very suddenly. It can occur due to say viral hepatitis or some unknown toxin, and that has a much higher toll on older individuals rather than younger patients. So older individual fulminant hepatic failure doesn't happen that much, thankfully, but if it does, it's a problem. The mortality is quite high. Okay, now there are other diseases such as hepatitis B, hepatitis C. It's rather more common in the East than in the West. The progression to cirrhosis. Now, only a certain population of hepatitis C patients will progress to cirrhosis. Older individuals, especially if you have a little bit of fibrosis in the liver, they'll progress faster to cirrhosis. And older donor livers also, these people can't if they donate. Now, hepatitis C patients, donors can donate their liver. We never used to take those, but they can donate to another patient with hepatitis C. But if you have an older patient with hepatitis C, we won't touch, because again, the ability of that to be damaged during the transplant process, is quite a lot. So we won't do that. So there's older livers themselves, get affected by hepatitis C a lot more than younger livers. That's the bottom line. And there are other diseases such as primary biliary cirrhosis, where the small bile ducts within the liver, they shrink and they cause a problem. It happens around in females around 30, 35 years old. But if you've got somebody living without a transplant at 50 and 60, the disease gets really bad, and it may not be compatible with life. But there are other diseases like autoimmune disease. Autoimmune is when the body has antibodies to itself, its cells, and it's a self-attack. Those sort of diseases die out as you get older, and liver is no exception. That can get better as one gets older. Now, this is a condition that's affecting the population more and more, and this is steatosis. Steatosis means accumulation of fat in the liver. Now, this is an issue that can happen with lifestyle. It's usually a lifestyle disease, So non-alcoholic fatty liver disease. That is, if people have alcohol, that's a different matter. The cause here. This is non-alcoholic fatty liver disease, usually associated with a metabolic syndrome, and it's a lifestyle issue. And they usually have insulin resistance and type 2 diabetes. But the good thing, so what happens, the fat accumulates in the liver by various metabolic processes, and I'll explain a little bit of that later. But the fat gets deposited in the liver. You can see it's all yellowish in color. The edges are all rounded. It's not like a nice liver, sharp edge, brownish liver. It looks fatty, and if you look at it, it looks like a pumpkin. So that sort of liver is a liver that's affected by this non-alcoholic fatty liver disease because of poor dietary intake, sedentary lifestyle, diabetes. It affects the liver. Okay, so now this is reversible, though. It is reversible, and I'm actually one example of that. I didn't progress to this level. I was about 20 kilos heavier, and I had fatty changes in the liver. So what did I do? I just did my usual, cut out all that nonsense that I was eating, fasting, all that helps. And today my liver has very little fat. My latest scan, thankfully, hopefully it will stay that way. But that's why I'm telling you this is because this is reversible. I've reversed it myself. Anybody can reverse it at an early stage. You let it go, you can't reverse it. Okay, smoking, all these lifestyle issues. So one has to correct lifestyle. Once you know exactly what's going on, you got to see if you can reverse it. And this, thankfully, is a reversible condition. And it's because of all this fat that's floating around the body. You've either consumed it in the diet, or already the patient is obese, and all the fat gets accumulated. And on top of that, you keep having the stresses that you input on the liver on a daily basis due to alcohol, due to your diet. And then suddenly what happens is this fatty liver slowly undergoes this change into a fibrotic liver, then goes on to develop cirrhosis. Now this has become a problem not only in the West, but increasingly in this part of the world. Okay, so this is a lifestyle disease, reversible. Unfortunately, hepatitis C in the United States used to be the biggest indication for transplantation, to change the liver, but it's no longer so. It's this disease, lifestyle disease, that's taken over, and it is slowly taking over this part of the world also. So now what happens when you find all these changes and as life goes on? What happens is basically the liver becomes shrunken. You see all this stuff here, it's all nodules, and there's all cirrhotic nodules over there. Okay, and what has also happened is there's a big tumor that's developed. So this sort of liver that is shrunk, fibrotic, cirrhotic, is very prone. That environment is very prone for cancer of the liver. So this is one of the ways in which cancer happens. You have fibrosis, you have cirrhosis, and you get hepatocellular cancer. Now, not just for non-alcoholic fatty liver disease. What happened there? Okay. So not necessarily non-alcoholic fatty liver disease, but viral hepatitis B and hepatitis C can also do the same thing. Okay, especially in an older liver, the same thing can happen, because what happens is they increase a whole bunch of genes that are favorable towards progressing in the direction of cancer. So all these, not only the fatty liver disease, not fatty liver disease, but NAFLD, viral hepatitis, anything that leads to cirrhosis is an environment for all these genes to be upregulated, and especially in the older liver, and it can progress to liver cancer. So, and that's why this thing has been, this term inflammaging is more and more popular these days. It's because it's an aging process driven by stimulation, and stimulated by a response to inflammatory markers. So that's what it is. And there's lower antioxidant enzymes that have been found, and all this can be this inflammatory changes because of poor diet, lifestyle, can be actually reversed. And this inflammation that goes on, it just speeds up the aging process in the liver. So you reduce all the inflammation, your aging will also slow down. And as somebody said the other day, you can't completely reverse aging, but you can slow it down, by modifying your lifestyle and identifying the toxins that affect your liver and reducing the consumption. Okay, so this is all these epidermal growth factor. Now I'm coming to this because I told you about the regenerative capacity of the liver, right? The liver can grow back. So, and people have done some work on it, and they've identified epidermal growth factor. This is this in younger livers, it is far more than in older livers. and that has the ability to regenerate. That's what gives the one of the factors responsible for the liver to regenerate so nicely is because all these and growth hormone and the other gene transcription factors, all of these are actually higher in younger livers compared to older livers. Now, I say younger and older again, it's not just the age, but it's also, I mean it in a disease sense of way. The more disease one has, the more insults you throw at the liver, the less these will be, and the less it'll have a chance to regenerate. So healthier livers, then you have all this. Even an older person, you have a good abundance of all these epidermal growth factor, growth hormone, and that helps the liver to regenerate. That's why it's we prefer it. Our patients recover better if they have preserved their liver, rather than throwing insults at it. So this is again to prove the point. This work has been done already, and older livers regenerate less and more slowly than younger livers, but that's also because they've been exposed to a lot of toxins, all through their lives. And we do see very often older people who have livers which are far better than say 60, 50-year-olds. So that also happens. So I would say that you go dig deeper and you'll find that there's been a lot of abuse going on. Okay, so I just wanted to say a little bit about transplantation because I've dabbled in transplantation for quite a few years. We have expanded our donor pool because there's not enough donors. There's so many people. There are thousands of people waiting for organs, but you don't have the organs. So we've always been trying to see how we can expand our donor pool so that more and more people can get transplanted, because the results of transplantation is so good. People can go back to a normal life after liver transplantation. So we've tried to include older donors, but people are hesitant to do that. But at even disease donation, the oldest donor we've used for cadaveric or diseased organ donation has been 74, 75. We've used the liver because it looks so good. We've biopsied it. We look at it under the microscope before we use it, and then we say, oh, it's good enough, and we will use it. But you have to match really your donor with your recipient. Okay, so you can't take unnecessary risks. You can't, you have to think of the recipient and how he's going to recover. So if you've got a healthy recipient who's got a cancer, you need to change his liver, then you might give him this liver. So there are ways in which you match the donor and the recipient. So that way we have learned over time to use these older donor livers also. And you keep them, don't preserve it too long, transplant it straight away. So there are various strategies you can do to actually use the older organs. And I think this age should not be a factor. Age should not be a limiting factor if one wants to donate organs. Okay, and this is again a liver that's being split into two. This is again a slightly older liver, and we've actually managed to split that into two and give it to two different people. So that is how we maximize the donor pool. But you have to make sure that your liver is a reasonably healthy liver before you dare do things like this. Because, I mean, see, the center where I worked had an experience of doing about 150 liver transplants a year, so they had a huge experience. So they could afford to do these things because they knew exactly when to take a risk and when not to. Again, it's still not very popular to use older donors, but it's becoming more and more a necessity rather than anything else. So I think I'm coming to an end to the end of my talk, and I'm coming back to this NAFLD and fatty liver. I want to come back to this for a minute before I finish, because I was just telling you, right? This is all part of the metabolic syndrome, and soft drinks those days, they use high fructose corn syrup. High fructose corn syrup. I think it has more or less disappeared from all the drinks now. But the problem that you see here, all these big round things, they're all fat droplets. So you take too much sweet drinks, too much carbs, Coke, Fanta, all that, that can increase the fat, the visceral fat, and see what it does to your liver. That's what it does. The fructose is very difficult to metabolize. It goes straight away, becomes fat in the liver. Okay, at least the glucose, it goes through a certain metabolic process, and it's converted to fat. Okay, but the fructose hits you really hard. It hits your liver really hard. So, this is becoming more and more popular now. People have realized it, and that's why you get all these diet cokes and diet this and diet that. So taking carbohydrates, sweet drinks especially can really, but luckily, high fructose corn syrup is disappearing from the market. So, and the reason I'm just saying that is because you can reverse that. See these little fat droplets, they can all disappear. What you need to do is to change your lifestyle. You need to change your lifestyle. You need to cut out all the sugary drinks and the carbs from your diet, extra carbs from you need carbs. You need to have a balanced diet, of course, but all those extra carbs you need to cut out, and you can also do some fasting. Fasting is very, very good for the body and is very good for the liver. You can just simply reverse all those things that I showed you, and there are various ways people have worked out the pathway how this can happen, and certainly you can see a scan. I told you about myself. You can just go do a scan after you do a period of fasting and cut out your carbs. You'll see the change in your liver within a couple of months, 2-3 months. You'll be able to see the difference. How the liver will react. And so fasting along with a low carb consumption is excellent. And there are various other benefits of fasting and all that. I think I have another talk on that coming up later. But you can do various scans, and you can see that your liver stiffness is decreased. Total body fat will be decreased if you combine these two with the low carb diet and fasting, intermittent fasting. So with that, I'll just stop. I just want to conclude by saying, obviously the insults that we hit our liver with on a daily basis, various drugs, alcohol, all that should be controlled. Reduce the exposure to disease, hepatitis B, hepatitis C. Please vaccinate yourselves if you haven't vaccinated against hepatitis B. We don't have a vaccination for hepatitis C yet, but good control of NCDs, that is non-communicable diseases, and that's what I was talking about, this non-alcoholic fatty liver disease, lifestyle diseases, metabolic syndrome, diabetes. So get some exercise, watch your diet, and screen yourself for cancer. There are certain screening processes at different ages that you have to do. So follow the CDC guidelines, and I think you will be fine. You won't have to worry. Okay, so what you're seeing is probably one end of it. I'm showing you one end of it, but the other end of it is that the liver is very forgiving. So you have to damage it really badly if you have to damage it. So with that, I'll finish and I'll take some questions. Thank you.
Okay, thank you, Prof. Raghu.
Yeah.
There's a question from the online audience. The question is, what minerals and vitamins or nutrition needed by the body in order to have a healthy liver? It comes from Mr. Lawrence Yap.
Okay, so well, there is no absolutely one magic silver bullet for this. What you need is you can avoid toxins rather than, see, our food, daily food contains, it's a balanced diet is all you need to take. Okay. However, I would say to you again, reduce the insults to your liver, and you have a nice, good, healthy diet. That's more than enough. You don't need to take any supplements, okay, unless you're deficient in something. So no need to take any supplements at all. I know that some of the pharma companies might be upset with me saying this, but I hardly ever prescribe any supplements except maybe when something is lacking. So if there's a vitamin D deficiency, yes, please do. So that way, you'll be fine. You reduce the insults. It's not as if the liver needs anything special to actually, do a good job.
Thank you, Prof. Raghu. Any other questions from the floor?
Yeah.
I want to find out if, for example, the consumption of statin over the long term,
Yeah.
how will it affect your liver?
Okay, that's a very good question. Thank you. It is a well-known fact that statins affect liver function. Okay, so if anybody is on statins, you have to watch your liver function very closely. There is a tendency to overprescribe statins, I think. I don't know, Dr. Wong, but one has to be really careful. It will affect liver function, and we've had to take a lot of people off statins. So not just statins, many other drugs can affect liver function, and you have to have a very close eye. You have to monitor your liver function every now and again. If you have to be on statins, because there's a medical need to do so, please, yes, take the statins, but watch your liver function, and don't, and you may have to control the dose.
Okay, any more questions from the floor?
Yeah.
Good morning. Just now you said that 70% of liver damage occurs before the LFTs increase start to show any changes. So what are the markers that we can do to detect earlier?
Okay, that's a good question. The answer is there is no effective marker so far that can detect liver damage very early. No effective one. Okay, so all we can do is we have other tests of liver function, which is looking at the prothrombin time, looking at the albumin content. All that again does not get affected early. It gets affected really late. And sometimes what we do is we do this fibroscan. You know, you can do a fibroscan to see whether there's any fibrosis of the liver. That is the latest technology. By doing simple ultrasound scan, it will tell you how much fibrosis there is. Fibrosis is the early stage of damage. You know, so first fatty liver, then our fatty liver can change slowly into fibrosis. So you can detect fatty liver, you can detect fibrosis. So blood test will not tell you. These an ultrasound might be able to. Even that occurs quite late, actually. You know, so really there is no one magic marker there, but I would say a fibroscan is probably the best way to do it.
Okay. Yeah, in your slide you mentioned about cancer screening. So what do you mean by that?
Okay. Again, if somebody is at high risk, then the best thing to do is to go for an ultrasound scan and a marker, alpha-fetoprotein. There is a marker for liver cancer that is known as alpha-fetoprotein. You can actually get that measured if you're at high risk. Now, some liver tumors do not produce alpha-fetoprotein. So a normal AFP does not mean that one does not have cancer. So it's a combination of getting an ultrasound scan done as well as an alpha-fetoprotein that would be a good screening tool for liver cancer.
Is alpha-fetoprotein a specific test? Because we have my personal patient, he has a level of alpha-fetoprotein about 12 for over 10 years, and did all the screening and we cannot find it. So
yeah.
So is it a good test?
Yeah, it's not. It's definitely it's you know, you can get it with other tumors. You got to look for other tumors. You know, for example, tumors of the gonads, they can sometimes produce alpha-fetoprotein. So you have to be really careful. If you don't find a tumor in the liver, then you have to look elsewhere. And if it's not there elsewhere, then it's an unexplained phenomenon. You know, sometimes you do have these patients, not just alpha-fetoprotein, CA19-9. You know, is another tumor marker. They come to you with, now they have some inflammation going on, and that can also increase all these tumor markers. You know, it's not just cancers that increase it. CA19-9 can go up even with any inflammation in the liver, so it can be a little misleading. So just because it is up also does not mean there's necessarily cancer. It might be some inflammation also going on. But you got to look at other sites to make sure that there's nothing producing alpha-fetoprotein.
From the slides, the high fructose syrup is causing major insult to the liver. So what about the sugars?
Sorry, I didn't get your question. Can you repeat that? Yeah.
Glucose syrup.
Yes.
Damage to the liver?
Yeah.
Yeah, the fructose causing insult to the liver, causing fatty liver.
Yeah.
So what about the fruits, the normal fruits that we eat? Is it
fruits,
considered as a fructose?
Yeah.
I mean,
now they contain natural sugars, you know. Now having fruits is not bad. If you have diabetes and you have fruits, yes, of course, that's not very good, you know. But we all know the benefits of fruits. So I'm not asking you to stop taking fruits, but then you add, you know, high fructose corn syrup to your fruit juice, that becomes really bad, you know. So have your fruit juice, have fresh fruit juice, no problem. But be careful if you have diabetes, or if you have a tendency to put on weight, you know, you have to be careful about fruits. One of the things I cut down when I wanted to lose weight, I lost 20 kilos. I just stopped taking fruit and fruit juices, you know. So every little, but that doesn't mean you need to do it you need to do it every day. If you're maintaining a reasonably good, you know, body weight and BMI, you don't need to cut anything out. What you're doing is correct, you know. So tailor it according to your needs.
Okay. In your slide, you mentioned that the liver doesn't have atherosclerosis. What is so special about liver that? Because
the microcirculation.
Yeah, because atherosclerosis affect the whole body, you know, everywhere, even our private parts. How come the liver is not affected?
The microcirculation. It's special.
What is so special about it?
It is special because it is in a large way. it is, you know, it is something to do with the immune system of the liver. Now, I can't really give you a 100% explanation to this. I don't know. I don't think anybody knows the answer to this, to be honest with you. But it's, again, what we think is that the liver immunology, the ability of the liver to protect itself is huge. You know, the microcirculation is so fantastic, it doesn't get affected unless you really give a lot of drugs or whatever it is to really hurt it, you know. So that's what apparently, you know, it protects the liver. Now, there might be, you know, the vessels are all contain, they all contain different layers, you know. You don't find those layers that you get in the arteries in the liver, you know, because it's like sinusoids just bathe the liver cells. So maybe that is the reason why it doesn't get affected by these changes. These changes of atherosclerosis affects, you know, your hardening of the arteries happens to arteries as you see it in the peripheries. That is most likely explanation.
Okay, we have another 3 more minutes. Maybe I'll finish off with questions that related to the traditional Chinese medicine. They always think about the liver as an organ that rests at night. So they said that you must sleep at a certain time, and you should not eat after maybe 10 or 11 o'clock. So is there any truth in a Western and scientific explanation?
Not that I know of. I've not heard that before, Dr. Wong, so maybe I should look into that, you know. But generally, we always say don't eat too late at night. You know, it is... it's you know, it's to do with it, I suppose you eat and then I mean the diurnal variation, the daily variations of your hormones, you know, it might be something to do with that, you know, and digestion. Certainly it's not good to just eat and just lie down, you know. You get heartburn, you get acidity, reflux, all that. So so perhaps it's to do with that, but you know, it's certainly something worth looking into, and I will look that up, give you an answer later.
Yeah, maybe I'll answer it my own questions. Actually, there's a study to show that if you eat after 10 or 11, the accumulation of fat is higher compared to when you're eating during the day. So there's a study to prove this. Yeah, but I can't give you the reference now. Okay, I think we'll end this talk. We end on time, and let's thank Prof. Raghu in the usual way for giving a very wonderful talk on liver. Thank you.
Thank you very much.